The following podcast is part of a certified educational activity titled Ongoing Immune Innovation in Head and Neck Cancer. Insights on checkpoint inhibitors, bispecifics, and other immunotherapies across disease settings. Access the entire activity and complete the post-test at peerview.com/SAT860. Downloadable slides and practice aids are also available.
Hello, everyone. I'm Dr. Aarti Bhatia from Yale School of Medicine. Welcome to Immune Innovation in Head Neck Cancers. I'm also pleased to welcome my colleague, Dr. Deborah Wong from UCLA Medical Center. And today we'll be discussing standard of care immunotherapy with immune checkpoint inhibitors in recurrent and metastatic head and neck cancers and nasopharyngeal cancer, and how these agents are starting to change modern management in definitive treatment settings. We'll also explore the rapid emergence of novel immunotherapy in the form of bispecific antibodies in the recurrent and metastatic setting. And then we've also collected some of the practical information we'll be discussing, including guideline updates and dosing strategies, and made them available as a downloadable practice aid, so you may want to access those resources. During today's presentation, we will learn that immunotherapy, which was until now being utilized in the treatment of recurrent and metastatic head and neck cancers, is now being increasingly integrated into treatment planning for patients with locally advanced disease. Anti-PD-1 agents have been in use for several years now, and that has enabled us to understand and characterize their dosing, their side effect profiles fairly well, so we can optimize safe treatment delivery of these agents. Excitingly, newer bispecific antibodies have shown the ability to synergize well with immune checkpoint therapy, particularly in patients with HPV-negative high-risk disease. And in today's talk, apart from reviewing these agents, we'll also discuss some best practices on multidisciplinary collaboration with our colleagues so we can deliver the most effective and personalized treatment for our patients with locally advanced and recurrent metastatic disease. So let's begin by reviewing current practices, recent changes, and some common challenges that we encounter when using immunotherapy in head and neck cancers. Multiple anti-PD-1 agents have been approved in the treatment of head and neck and nasopharynx cancers. Pembrolizumab is approved in the first-line recurrent metastatic setting as monotherapy for patients with PD-L1 CPS greater than equal to 1 score, and in combination with platinum doublet, regardless of the PD-L1 score. It's also approved as monotherapy post-platinum exposure and in the perioperative setting for patients with PD-L1 CPS greater than equal to 1. Nivolumab is approved as monotherapy post-platinum exposure in patients with recurrent metastatic disease. Both Pembro and nivolumab have subQ formulations that are FDA approved now for several adult malignancies, including head and neck cancers. And then toripalimab and penpulimab both have FDA approval in combination with platinum and gemcitabine in the first-line treatment for patients with recurrent metastatic nasopharynx cancer, and as monotherapy post-platinum exposure in recurrent metastatic nasopharynx cancer. Tislelizumab has approval in Europe, Canada, and China in combination with platinum-based chemo for first-line treatment of recurrent and metastatic nasopharyngeal disease, and as monotherapy after platinum exposure in nasopharynx cancer. And this chart outlines the dosing schedules for these different anti-PD-1 agents. Important to note here, toripalimab, penpulimab, and tislelizumab are all dosed intravenously every 3 weeks. Pembrolizumab can be used intravenous every 3 or 6 weeks, as well as subQ every 6 weeks. And nivolumab can be dosed intravenously every 2 or 4 weeks or subcutaneously every 2, 3, or 4 weeks based on the indication. It's, of course, also important to be aware of and on the lookout for immune-mediated adverse events. These are triggered in an autoimmune fashion by enhanced T-cell activation in normal tissues. And across several different trials of anti-PD-1 agents and in different tumor types, about 30 to 50% of patients will experience some immune-related adverse event of any grade. About 7 to 10% of patients will experience a high-grade immune-mediated adverse event. The toxicities can be very variable, can involve pretty much any organ system, and can occur in a pretty unpredictable temporal association too. So it can start as early as a few weeks after treatment start to several months later, and sometimes can occur even after treatment has been discontinued. Toxicities are typically graded in severity using the CTCAE tool. For grade 1 adverse events, we typically continue the anti-PD-1 agent while symptomatically managing the side effects. For grade 2 events, the drug is usually temporarily held and oral steroids are initiated with a taper. Once the taper is complete and the toxicity subsides to a grade 1 or better, immune checkpoint therapy can be reinitiated. For grade 3 or higher events, immune checkpoint therapy is usually discontinued, sometimes needs to be permanently discontinued. Patients may need to be hospitalized for monitoring of the adverse event and for starting higher dose IV steroids. If the toxicity subsides, the steroids are switched to PO and a prolonged slow taper is completed. If response to steroids is inadequate, sometimes a second immunosuppressive agent may also need to be added. The decision to re-challenge with immune checkpoint therapy is made based on the organ system involved. So we typically will avoid re-challenge after life-threatening adverse events like myocarditis or myasthenia gravis or severe pneumonitis. Despite the approval of immune checkpoint therapy in head and neck cancer, the prognosis remains poor, especially for patients with HPV negative disease. And there's clearly an unmet need for more effective systemic lines of treatment. A recent meta analysis evaluated overall survival that was stratified by HPV status in recent therapeutic trials in head and neck cancer and found that both in the first line and second line setting, overall survival was significantly higher for patients with HPV positive disease. With this context, I'd now like to invite my colleague, Dr. Wong, to lead us into our next section, where we'll discuss the current standard of care systemic therapy for recurrent metastatic disease and review some promising agents in clinical trials.
Great. Thank you so much, Dr. Bhatia. So let's dive into how we can incorporate these immunotherapies that we've just discussed into the treatment for recurrent and metastatic head and neck cancer. So let's start with a case. This is a 65-year-old man who initially presented with a CT4A-N1 local regionally advanced larynx cancer. He undergoes treatment with surgery followed by chemoradiation. Unfortunately, 9 months later, he presents with local regional recurrence and still has a good performance status with an ECOG performance status of 1. And so with this case in mind, Dr. Bhatia, how would you approach next steps in his treatment and management?
So usually with anyone with local regional recurrence, we're asking the question, is this someone that can be salvaged with surgery? Usually these patients get referred to surgical oncology to have that discussion. At the same time, we also will typically obtain a PD-L1 test because, if surgery is not an option, and we have to consider systemic therapy, presuming they've received prior radiation, which does not permit more radiation at this time, then, if salvage surgery is not an option, then we're really thinking about palliative systemic therapy. And it's important to know the PD-L1 CPS score to decide if immunotherapy is something that might benefit this patient. So usually with a higher CPS score and for someone that's not too symptomatic, you can consider pembrolizumab monotherapy. For patients who have a lower CPS score or are more symptomatic, with airway at risk or swallowing at risk, we're really thinking about adding more than to pembrolizumab, maybe combining with chemotherapy.
right? I completely agree with you, Dr. Bhatia, and it's we undertake a similar approach in my practice here. Certainly, in the setting where patients have already received surgery and radiation, oftentimes these aren't very good options in the recurrent setting. And so, with regard to PD-L1 testing, it sounds like you do this pretty much at the time of recurrence, at least current as per current standard of care. So here are the NCCN guideline recommendations for systemic therapy for patients with recurrent and metastatic head and neck squamous cell carcinoma that is non-nasopharyngeal. So immunotherapy is the mainstay of treatment for recurrent unresectable or metastatic disease. That is those who, for patients who do not have a surgical or radiation option. In the frontline setting, pembrolizumab with chemotherapy, most commonly cisplatin or carboplatin with 5-FU, is a standard of care regimen. And for patients whose tumors have a PD-L1 CPS score or combined positive score of 1 or higher, pembrolizumab monotherapy is an available option. In the second line setting, nivolumab as monotherapy can be used if the patient has disease progression on or after platinum chemotherapy. Similarly, pembrolizumab can also be offered as monotherapy. Here are the NCCN guidelines for CPS, PD-L1 CPS testing in the context of recurrent and metastatic head and neck squamous cell carcinoma. So guidelines recommend that any patient with recurrent or metastatic disease should have PD-L1 expression evaluated by combined positive score, and that this CPS testing should be part of the recommended diagnostic workup whenever systemic therapy is planned. And that's, of course, because this will help us to decide whether the patient would be appropriate for pembrolizumab with or without chemotherapy. In terms of how the testing is performed, PD-L1 testing is performed by immunohistochemistry staining using the combined positive score, which reflects expression on both the tumor and the immune cells. And as I mentioned, the CPS score is then used to guide systemic therapy selection, including the choice of when to incorporate PD-1 based therapies. This is really based on the practice-changing Keynote-48 study, which established PD-1 therapy as standard of care for frontline recurrent and metastatic head and neck squamous cell carcinoma. Keynote-48 was a randomized, double-blinded phase 3 study open globally that enrolled 882 patients and randomized them 1:1:1 to what was then the standard of care, platinum plus cetuximab chemotherapy, in comparison to pembrolizumab monotherapy or pembrolizumab with platinum-based chemotherapy. The study was designed to compare cetuximab with chemotherapy compared to each of the pembrolizumab-containing arms. And here are the high-level data evaluating overall survival for cetuximab and chemotherapy and pembrolizumab. As shown on the left, for patients whose tumors have a PD-L1 CPS score of 20 or higher, the median overall survival for pembrolizumab alone was 14.9 months compared to 10.8 months for cetuximab with chemotherapy. For patients with a PD-L1 CPS score of 1 or higher, the median overall survival was 12.3 months for pembrolizumab compared to 10.4 months for cetuximab plus chemotherapy. And in the total population, the median overall survival was 11.5 months compared to 10.7 months, which was not statistically significant. And so based on these data, pembrolizumab monotherapy is an approved treatment option for patients whose tumors are PD-L1 CPS 1 or higher. So let's move on to a second case of recurrent and metastatic nasopharyngeal cancer. So here we have a 55-year-old woman with a diagnosis of EBV or Epstein-Barr virus positive nasopharyngeal carcinoma. She undergoes gemcitabine and cisplatin induction chemotherapy followed by chemoradiotherapy. Unfortunately, 24 weeks later, she presents with a 1.5 centimeter liver lesion, which is biopsy proven to be metastatic disease. And so in this case, Dr. Bhatia, if I can pick your brain, how would you approach treatment for this patient?
So this is a patient with EBV positive nasopharynx cancer that's now metastatic to the liver. She seems to have progressed about 6 months after first receiving chemotherapy. So technically, we still consider her to be chemosensitive. And in the first line setting for this disease, the current standard of care is platinum and gemcitabine based chemotherapy in combination with toripalimab. Contrary to mucosal head neck cancers, we don't typically rely on PD-L1 expression to guide the incorporation of immunotherapy in this disease. Because nasopharynx cancer typically tends to be a highly inflamed tumor with a lot of lymphocytic infiltration in the tumor microenvironment. And these patients tend to benefit from the addition of immunotherapy regardless of their PD-L1 status. So that would be my go-to regimen.
And as per NCCN guidelines, you are right on in line with those. And so this slide summarizes NCCN recommendations for for chemoimmunotherapy for recurrent and metastatic nasopharyngeal cancer. So in the frontline setting, the preferred regimen is to use cisplatin and gemcitabine in combination with toripalimab. If the patient did not receive toripalimab in the frontline setting, then it can be used in the subsequent lines of therapy. And other recommended regimens in the frontline setting are listed below here on the slide. This guideline recommendation is really based on the data from Jupiter 2, which was a randomized study evaluating the addition of toripalimab with gemcitabine and cisplatin for patients with recurrent and metastatic nasopharyngeal cancer. In this study, patients with recurrent and metastatic nasopharyngeal cancer were randomized 1-to-1 to a toripalimab with chemotherapy comprised of cisplatin and gemcitabine, followed by toripalimab maintenance, compared to placebo and chemotherapy. And as shown here, these are the separation, the curves here. So you can see there's a significant separation of the curves in terms of progression-free survival, as shown on the left, as well as overall survival on the right. And in fact, at 1 year, the 1 year overall survival was 90.9% compared to 87.1%. At 2 years, we see further separation to 78% and 65.1%. And at 3 years, 64.5% versus 49.2%. And so overall, the median overall survival when we add toripalimab with chemotherapy was 64.8 months compared to 33.7 months for placebo plus chemotherapy. And so really this has solidified the role of toripalimab with gemcitabine and cisplatin for a frontline recurrent and metastatic nasopharyngeal cancer. And so with this as a background, this is the current standard of care, but unfortunately, many patients with recurrent and metastatic head and neck cancer will recur despite the best available treatment incorporating immunotherapy. And so newer and better treatments are fortunately emerging. And so in this next segment, we will foray into what's kind of emerging on the landscape for recurrent and metastatic head and neck squamous cell cancer. And so starting with the case here, this is a 58-year-old man with HPV or P16 negative recurrent and metastatic head and neck squamous cell carcinoma who has a PD-L1 CPS score of greater than 1 and an ECOG performance status of 1. He had prior chemoradiation for laryngeal cancer and now presents with disease progression with distant metastatic disease, including lung and bone metastases. And so overall, what are your thoughts in terms of prognosis for this patient with HPV negative disease?
So unfortunately, like we talked about earlier too, prognosis is poorer for patients with HPV negative disease. The median overall survival is about 12 to 13 months. And that is with immunotherapy, with platinum-based chemotherapy in the first line setting. So we're always exploring, other options. Is there something better? Is there a clinical trial that might possibly allow this patient to get a more effective combination with immunotherapy?
Yes, I agree with you. And I think, in addition, I think there's a great appetite for patients who have already gone through pretty intensive chemoradiation to have treatment that does not involve further chemotherapy. And so I think a lot of the emerging molecules and treatments are really new bispecifics that are not technically chemotherapy. And so one such agent is Ficerafusp alpha, which is a bispecific antibody targeting EGFR and TGF beta, both of which we know are poor prognostic drivers for HPV negative disease. As shown in this schema for Ficerafusp alpha, it has one arm which targets EGFR and another area of the molecule that can trap TGF beta. And so Ficerafusp alpha is designed to enable tumor penetration of immune cells by remodeling the fibrotic tumor microenvironment, which we hypothesize may be what's driving the deep and durable responses that I will present. So these are data from the ongoing phase 1 clinical trial evaluating Ficerafusp alpha in combination with pembrolizumab. In the cohort of frontline recurrent and metastatic head and neck squamous cell carcinoma patients who are HPV negative, there was very dramatic and promising activity that's been demonstrated to date. These data were presented at ASCO of 2025, evaluating patients treated with Ficerafusp alpha, which was given weekly, in combination with pembrolizumab, given every 21 days, in patients who had HPV negative cancers arising from the oral cavity, oropharynx, hypopharynx, and larynx. And all of these cancers were PD-L1 CPS 1 or higher. As you can see from the waterfall plots, there were deep and dramatic responses in many of the patients. The confirmed objective response rate was 54% in this cohort of patients. And 80% of patients in this group experienced greater than or equal to 80% tumor shrinkage. So quite dramatic. And if you recall, particularly notables for patients with HPV negative recurrent and metastatic head and neck squamous cell cancers, many of them present with local regional recurrent disease. And so they are very symptomatic. So to have these deep responses is particularly meaningful from a quality of life perspective. In terms of other efficacy outcomes, the median progression-free survival was 9.9 months. The median duration of response, 21.7 months, and the median overall survival was 21.3 months. So quite impressive if you recall that the median overall survival for HPV negative patients, even those treated with pembrolizumab, was only about 9 or 10 months. Several doses of Ficerafusp alpha have been evaluated in combination with pembrolizumab, and lower doses also are effective. So the data I just presented to you was that for 1,500 milligrams of Ficerafusp alpha. This data here on this slide are the data for 750 milligrams of Ficerafusp alpha with pembrolizumab. Similar to the prior slide, you can see really dramatic responses in the majority of the patients in this cohort. The objective response rate in the efficacy evaluable population was 57%, with 10% complete responses. The disease control rate was 83%. And the median time to response was 1.6 months. So patients can have a rapid a tumor shrinkage. And consistent with the 1,500 milligram cohort, there were deep responses seen in 29% of patients. And I should also point out that on this waterfall plot, the patients are separated, and in green are patients who have a PD-L1 CPS score of 20 or higher, and those in blue are those with CPS 1 to 19. As you can see here, responses were seen in both CPS low and CPS high patients. And so based on these data, the FDA has granted ficerafusp alfa a breakthrough designation in combination with pembrolizumab for frontline recurrent and metastatic head and neck squamous cell carcinoma. And these really have formed the foundation and the basis for this phase 2/3 randomized study, which is a registrational study called FORTIFY-HN. And so FORTIFY-HN is assessing ficerafusp alfa in combination with pembrolizumab in patients with HPV negative disease in comparison to placebo plus pembrolizumab. The initial phase 2 portion of the study will be used to determine the optimal biological dose. And then based on this phase 2 portion, the arm A or arm B dose will be chosen to proceed to phase 3. The primary endpoints for this phase 3 study are ORR and overall survival. So next I'll pass it on to Arti to discuss the data for petosemtamab.
Thank you, Dr. Wang. So switching gears a bit to another bispecific antibody, petosemtamab targets EGFR and LGR5, which is a protein expressed on cancer stem cells. This drug works in three distinct ways: by EGFR ligand blocking, through EGFR receptor internalization and degradation in LGR5 positive cancer cells, and by mediation of the innate immune system, by activation of the innate immune system by antibody-dependent cellular phagocytosis, and by ADCC effect. Based on data from early phase trials with this agent, both as monotherapy in platinum and checkpoint refractory patients, as well as in combination with pembrolizumab in the frontline setting, the FDA granted petosemtamab a breakthrough therapy designation. Efficacy outcomes from a phase 2 trial of petosemtamab in combination with pembrolizumab as first-line treatment for PD-L1 positive recurrent and metastatic head and neck cancers were reported at ASCO in June last year. And the combination demonstrated a 63% objective response rate in a cohort of 43 evaluable patients. Responses were seen across B16 subgroups and CPS subgroups, and the median progression-free survival was 9 months. Median overall survival was not yet reported, but approximately 80% of patients were alive at 12 months. Phase 3 trials with petosemtamab are currently ongoing. The LIGER Head and Neck 1 trial is enrolling patients with treatment-naive PD-L1 CPS 1 or higher recurrent metastatic head and neck cancers. Patients are being stratified by HPV status for oropharyngeal primaries, by ECOG score, and by CPS score, and they are randomized in a 1:1 fashion to receive pembrolizumab monotherapy or pembrolizumab in combination with petosemtamab. And similarly, the LIGER Head and Neck 2 trial will enroll patients who have progressed on anti-PD-1 therapy as well as platinum-containing chemotherapy. These patients will also be stratified by HPV status for oropharyngeal primaries and by ECOG performance status, and then randomized 1:1 to receive petosemtamab or investigator's choice standard of care systemic therapy. And the last bispecific antibody that we'll talk about today is amivantamab. This is also being investigated currently in head and neck cancer treatment. This drug targets EGFR and MET. We know that resistance to cetuximab in HPV negative tumors in particular can be driven by MET amplification. Along with inhibiting both EGFR and MET signaling, amivantamab can also exert an ADCC effect by recruiting immune cells to destroy tumor cells. And these are results from the Origami 4 trial, which enrolled patients with recurrent or metastatic head and neck cancers. Several different treatment cohorts were investigated. And this abstract from ESMO last year presented results from cohort 1, which tested the efficacy of amivantamab monotherapy in patients with HPV negative, platinum and checkpoint therapy refractory recurrent or metastatic cancers, head and neck cancers. The primary endpoint was objective response rate. The efficacy evaluable population included 38 patients, had a median follow-up of 8.3 months. An objective response rate of 45% was reported, with the clinical benefit rate of 76%. Responses were again rapidly induced, with a median time to response of 6 weeks. Median progression-free survival for all 38 patients was 6.8 months. Median overall survival was not reached at a follow-up of 8.3 months. So these are, again, very significant, very meaningful numbers for this pan-refractory, high-risk, and symptomatic population. And these are some representative scans of patients who had a tumor response. So you can see tumor shrinkage for these two patients in the lungs and in the mediastinum. And these are results from cohort 3 of Origami 4, which tested the combination of amivantamab and paclitaxel in patients who had previously progressed on immune checkpoint therapy and had HPV negative recurrent metastatic head and neck cancers. This was a small cohort of patients, about 11, but 64% were able to achieve partial or complete responses. And amivantamab is next being explored in the first-line setting in the pivotal Origami 5 trial. So this is a randomized phase 3 study in treatment-naive HPV-negative head and neck squamous cell cancers. This trial will randomize about 500 patients in a 1:1 fashion to receive either standard of care platinum, 5-FU, and pembrolizumab, or platinum amivantamab and pembrolizumab. So with these newer agents on the horizon, it's important to familiarize ourselves with the dosing schedules, and it's outlined in this chart. So important to note the differences between these three bispecific antibodies that we've talked about. Amivantamab is administered subcutaneously and is dosed by weight, starting with the lower first dose to minimize the risk of infusion-related reactions. And then it's administered weekly during cycle 1 to rapidly achieve a steady state concentration. Afterwards, it's dosed every 3 weeks, again, subcutaneously. Petosemtamab is dosed intravenously every 2 weeks, and ficerafusp is the dose like we heard about. It's still being optimized. 2 different weekly doses are being explored in the phase 3 trial in combination with pembrolizumab. It would also similarly be useful to know the side effect profiles of these agents. All these drugs have an EGFR inhibitor backbone. So acneiform rash, which is a class effect seen with EGFR targeting therapies, is a common side effect across all 3 agents. Amivantamab can additionally have side effects related to MET inhibition, which typically include hypoalbuminemia, lung inflammation seen rarely, sometimes edema as a result of the hypoalbuminemia. Because of subcutaneous administration, the rate of significant administration reactions was low in their early phase trial. Petosemtamab had a slightly higher rate of infusion-relation reactions, but it could be manageable with pre-meds and prolonged infusion time. And in Pfizer-Alpha, in addition to EGFR targeting toxicities, anemia occurred in almost half the patients on the initial early phase trial. In our next section, we'll review recent data around the use of immune checkpoint therapy in the locally advanced disease setting and how this has impacted clinical practice and treatment coordination with our colleagues in other specialties. So let's start with the case here. A 59-year-old female with a smoking history presents with resectable P16 negative stage 3 oropharynx cancer. She is staged as T2N1. She has a performance status of 1. On imaging, there is a 2.8 centimeter tonsillar primary and a single ipsilateral level 2 lymph node. Her PD-L1 CPS score is 10. She has borderline renal function with a creatinine clearance of about 58. So, Dr. Wong, I'd like to, check in with you, see how you would now manage a patient like this. How would you think about perioperative treatment if she's being planned for surgery? Would you try to avoid chemotherapy in the definitive or adjuvant setting given her renal function?
Yeah, I think this is a really exciting time for patients with locally advanced but resectable head and neck squamous cell carcinoma. Certainly, for this patient with a stage 3 HPV negative oropharyngeal squamous cell carcinoma, non-operative options can include cisplatin plus radiation in the definitive setting. With curative intent. But of course, in the setting where the patient has borderline renal function or may not be amenable to platinum-based chemotherapy because of debilitating neuropathy or other factors, certainly if the patient is resectable, then that is something worth discussing and sort of underscores the importance of incorporating and involving the various specialists who treat head and neck cancer, the head and neck surgeons, the radiation oncologists, and others. And so, given the PD-L1 CPS score of 10 and the fact that she has resectable disease, then she would be a candidate for perioperative pembrolizumab based on new data. And so that would definitely be a consideration for this patient, especially if we wanted to try to omit cisplatin chemotherapy. And so I think that this is a great case with many different options. And so at our institution, really, it's a combination of collaboration with the multidisciplinary team, as well as patient factors as well that will kind of ultimately decide on the best treatment option for this patient.
Completely agree. Thank you for your insights. So we know from multiple phase 3 trials from the early 2000s that despite multimodality treatment involving surgery, adjuvant chemoradiation, about 30 to 40% of patients with locally advanced head and neck cancer relapse within a year. And prognosis is particularly worse for patients with HPV negative disease, with 5-year survival being less than 50%. This is vastly different from patients with HPV positive disease who have a much better prognosis. So the question is, and I think it's been answered, can anti-PD-1 therapy help improve outcomes for patients, especially with HPV negative disease? And 2 large trials recently helped answer this question. The first was Keynote 689. This was a phase 3 trial that randomized about 700 patients with resectable stage 3 or 4A tumors of the oral cavity, oropharynx, hypopharynx, or larynx in a 1:1 fashion to receive either standard of care surgery followed by risk stratified radiation or chemoradiation, or to the experimental arm of 2 cycles of neoadjuvant pembrolizumab, followed by surgery and then risk stratified radiation or cisplatin radiation, but given concurrent with pembrolizumab, and then maintenance 12 cycles of adjuvant pembrolizumab. The primary endpoint was event-free survival, And as you can see in these Kaplan-Meier curves, the 3-year event-free survival was significantly improved in the pembrolizumab arm, with a hazard ratio of 0.73 and a p-value of 0.008 for the entire population. The benefit was seen regardless of CPS scores, so you can see a benefit and separation of the curves in event-free survival for both the CPS greater than 1 and CPS higher than 10 population. Overall, patients were able to receive a lower median dose of adjuvant radiation, and fewer patients needed concurrent cisplatin on the neoadjuvant pembrolizumab arm because they were less likely to have high-risk features on pathology. And NIVO post-op was another randomized phase 3 trial. This tested the addition of nivolumab to standard of care in high-risk and resected head and neck cancers. This study enrolled 680 patients. They'd all had surgery for squamous cell cancer of the oral cavity, oropharynx, larynx, or hypopharynx. They had a pathologic stage of 3 or 4 and high-risk pathologic features at the time of surgery, which was defined as extracapsular extension in the neck nodes or positive margins. These patients were randomized to standard of care 3 cycles of high-dose cisplatin and 66 gray of radiation versus nivolumab concurrent with radiation and cisplatin, followed by 6 cycles of adjuvant nivolumab. The primary endpoint was disease-free survival, and median follow-up was 30 months. As you can see here again with the separation of the curves, there was an improvement in disease-free survival from 52% to 63% at 3 years in favor of nivolumab, with a hazard ratio of 0.76 and a p-value of 0.03. And these trials have led to a change in our current standard of care practice. So perioperative pembrolizumab is now recommended for patients with P16 negative and PD-L1 CPS 1 or higher, stage 3 or 4A disease that is being planned for upfront surgery. And this brings us back, as Dr. Wong alluded earlier, to the need for close collaboration with our colleagues in other specialties. Patients with head and neck cancer are a high-need population. There are several critical structures in the head and neck that are at risk during the course of treatment. And in addition to seeing the treating teams of surgeons, radiation oncologists, and medical oncologists, they also benefit from very close follow-up and collaboration with ancillary teams like dentists, nutritionists, speech-language pathologists, physical therapy, and social work. So if we need to put perioperative treatment into the mix, it's very necessary to reimagine our workflow and to minimize treatment delays and disruptions. So at our institution, we found it particularly helpful to have a PD-L1 test done on all new diagnoses of head and neck cancer now. And then any patient who has a stage 3 or higher cancer gets referred to MedOnc to consider perioperative pembro. Once cycle 1 of pembrolizumab is scheduled, we coordinate back with the surgeons to secure a date for surgery after cycle 2, knowing that it takes sometimes a couple weeks for the surgeons to schedule a surgery date. And during our appointment for cycle 2 of pembrolizumab, we coordinate a follow-up with medical oncology and radiation oncology post-op, usually within 2 or 3 weeks, to review the pathology and plan adjuvant therapy. And with that, we come to our last case for this session. This is a 52-year-old male who presents with an EBV positive, non-keratinizing nasopharynx cancer and an ECOG performance status of 1. His tumor is staged as T4N1M0. He has normal renal function but has baseline tinnitus and mild hearing loss. And I'd be curious to hear Dr. Wong's thoughts and how she would recommend managing this patient.
Yeah. With today's standard of care treatment, this would entail induction chemotherapy with cisplatin and gemcitabine, followed by chemoradiation. But of course, in this particular patient who has baseline tinnitus and some mild hearing loss, we would have to carefully counsel a patient about cisplatin chemotherapy and the risks of worsening hearing loss, in addition to other toxicities, including renal toxicity and neuropathy. And so, certainly, while this treatment is currently standard of care, and while it can be effective, um, uh, morbidity wise, certainly, if there were an option to avoid cisplatin chemotherapy, I think that would be a very preferred, very much preferred by both physician and patient. And so, although it's not currently standard of care, there are emerging data evaluating the role of immunotherapy as in combination with chemoradiation for locally advanced nasopharyngeal cancer. Including some data that will review evaluating omission of cisplatin or minimization of cisplatin for locally advanced nasopharyngeal cancer. And so, going back to current guidelines for locally advanced nasopharyngeal cancer, really treatment is not surgical, but centered on radiation and chemotherapy. So at the top, we have for early stage nasopharyngeal cancer, T1 or T2 disease, we have definitive radiation with or without concurrent systemic therapy. For higher stage disease, the standard of care is concurrent systemic therapy with radiation, with the consideration to add induction chemotherapy, so even more chemotherapy on top of chemoradiation. And for locally advanced disease, so T3 and 1 through 3, T4 and 0 to 3, or N2 or N3 disease, induction chemotherapy followed by systemic therapy with radiation is category 1 recommendations per NCCN guidelines. One could undertake concurrent cisplatin chemotherapy with radiation followed by adjuvant chemotherapy. And a concurrent systemic therapy with radiation also can be considered. And certainly in this setting where we have locally advanced nasopharyngeal cancer, which is at risk for relapse, clinical trials are an option as well. And so, with regard to clinical trials, there have been a few clinical trials evaluating the addition of immunotherapy to chemoradiation for nasopharyngeal cancer. This is high-level summary of data for the Continuum trial, which was presented at ASCO 2023. In this study, this is a randomized phase 3 study, which enrolled 425 patients with nasopharyngeal cancer. And patients were randomized to standard therapy comprised of gemcitabine cisplatin induction followed by cisplatin radiation, or to the investigational arm, in which gemcitabine, cisplatin, and sintilimab, an anti-PD-1 agent, was used as induction therapy, followed by cisplatin radiation and sintilimab. And sintilimab was given for 6 doses after cisplatin radiation. And as shown here, event-free survival was better at 3 years compared to standard therapy. It was 86.1% at 3 years compared to 76% for standard therapy. If you look at the forest plots, seeing that in the total population, this seemed to favor the addition of sintilimab, and particularly there seemed to be benefit in the N1 subgroup of patients. In addition, the risk of distant metastatic disease and local regional recurrence was also reduced with the addition of sintilimab to induction chemotherapy followed by chemoradiation. The Diamond study is a second study evaluating the addition of anti-PD-1 to definitive treatment for nasopharyngeal cancer. In this case, the anti-PD-1 agent was toripalimab. In this study, which was also a phase 3 randomized study, 532 patients were evaluated and randomized here to the standard treatment arm, which was chemotherapy, but here with the addition of toripalimab, followed by chemotherapy with radiation. and toripalimab, versus the concurrent cisplatin-sparing group in which toripalimab was given with gemcitabine cisplatin as induction therapy, but with the radiation portion, no cisplatin was given. Instead, toripalimab was given. And here, the event-free survival as shown in this curve was quite similar between the standard therapy group and the concurrent cisplatin sparing group, indicating that perhaps one can omit cisplatin from radiation for patients with locally advanced nasopharyngeal cancer. As shown on the right, toxicity, as measured by all-grade vomiting, was also reduced, as you might expect, in the cisplatin-sparing group. And so the Continuum study and the Diamond study are intriguing data, indicating that that perhaps in the future we may see an emerging role for the addition of immunotherapy in the locally advanced setting for nasopharyngeal cancer. And so with that, I will wrap up our discussion today on immunotherapies for the treatment of head and neck cancers. In conclusion, anti-PD-1 therapies have changed the treatment landscape for recurrent and metastatic head and neck cancer, including both head and neck squamous cell carcinomas as well as those arising from the nasopharynx. In the frontline setting, pembrolizumab alone or in combination with chemotherapy represents the current standard of care for recurrent and metastatic head and neck squamous cell carcinoma. And for nasopharyngeal cancer, toripalimab with cisplatin and gemcitabine is the frontline standard of care. Moving forward, we are seeing emerging very exciting data on bispecifics targeting EGFR, particularly for patients with HPV negative recurrent and metastatic head and neck squamous cell carcinoma. Perioperative immunotherapy with pembrolizumab is a new standard of care for patients with locally advanced but resectable head and neck squamous cell carcinoma, and will increasingly play a role in treatment of such patients, and underscores the need for close multidisciplinary collaboration and care. And finally, for nasopharyngeal cancer, emerging data highlight a potential role for the addition of immunotherapy to chemoradiation for these patients. So with that, I want to thank you all for joining us today for this scintillating discussion on immunotherapy for head and neck cancer. Dr. Bhatia, many thanks to you for your insights and your expertise on this subject.
Thank you, Dr. Wang. It was a pleasure to be a part of this program.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by educational grants from Bicara Therapeutics Inc., Coherus BioSciences Inc., Johnson & Johnson, and Merus. To access all materials for this activity, visit peerview.com/SAT860.